for joining us as we celebrate social prescribing in all its forms across the northeast and North Cumbria. On behalf of VONNE and the Healthy Communities and Social Prescribing Programme, you are all very welcome. I'm Richard Boggy and I'll be your host for the next 2 hours, and I'll be ably assisted by my colleague Jen Hewitt, and Fran is also doing the slides for us. Thank you. I lead VONNE's work on social prescribing, and I'm a member of the wider VONNE Health and Wellbeing team that works with system partners to ensure the VCSE plays a full role in health and care, both strategically and operationally across the northeast and North Cumbria. Next slide, please, Fran. Yeah, I think we ought to start the recording. Sorry. Yeah, so
it's already started, Richard.
Okay, cool. Right, thank you. I'm a little bit hoarse this morning after shouting a lot last night. A few items of housekeeping. So this session is being recorded and it will be shared with people afterwards, yourselves and other people who maybe wanted to see this but couldn't be here this morning. So if you don't want to be seen in the recording, then you can turn your camera off. Please keep your microphone muted unless asked to speak, and that will just help keep everything manageable for everyone. Live captions are available for this session. You can find those if you go to the More button, which I believe is kind of 3 dots, and in there there's a button to do with language and speech, and you'll find that you can enable captions there. All the slides and the recording will be shared with you afterwards, so you don't have to worry about taking notes or anything like that. Could I ask, just for access reasons, because I'm blind and I'm using audio text-to-speech software, that we minimize the use of chat, just so that, because if I've got all the chat going in one ear, I won't be able to kind of hear myself think. So that would be really helpful if we can do that. There will be the opportunity to ask questions of speakers, and we can do that when they've finished their presentations. And at that point, if you have a question, you can either raise your hand, or if you'd rather not speak, then pop your question in the chat and we can pick it up from there. If we don't have time to answer every question, because we've got quite a lot to get through, then we will take the question away and come back to you. There will be a comfort break just before 11, hopefully, if we can stick to time. Next slide, please, Fran. So what we got in store for you today. I'll start in a moment. I'll set some context for this event, and then I'll hand over to our speakers. So first, we'll hear from Simon Bromhead from Ways to Wellness, an organisation that has been at the forefront of innovation in social prescribing in our region. After Simon, we'll hear from Sarah Penn at Cumbria CVS. Sarah's been doing some fantastic system work over in North Cumbria, and I'm very grateful that she's able to share some insights with us this morning. We'll then have a break, after which Jen will introduce our Power of People video. I won't say too much about that, apart from it's brill, so I'm looking forward to sharing it. I hope you'll enjoy it. And then we will hear from our third speaker, Dr. Anna Basu from Newcastle University and Newcastle RVI, who will share some insights from her work with children and young people and their families, and the difference that social prescribing is making to their recovery. Then we thought it was also important to hear direct from a social prescriber about their work. So I'm delighted that Julie Sinclair Day has agreed to talk to Lucy Cushley about her work at Teesside Mind as a link worker in Middlesbrough. Finally, I'll wrap things up with a few words about what's next for the Healthy Communities and Social Prescribing Programme as we head into a new financial year. Next slide, please, Bran. So before we get into the speakers, why are we celebrating Social Prescribing Day? I think it's really important that we celebrate the work that's going on across our region. It's achieving great things, supporting some of our most marginalised people with their greatest health inequalities. So why would you not want to celebrate that? We also want link workers to feel valued. National feedback suggests this is not always the case. This is an important section of the health and care workforce. And you'll see examples of their work this morning, which I think will demonstrate just how valuable their work is. And we need social prescribing to be understood and valued. It's a key part of neighbourhood health and care, of prevention work, and of that left shift that the government wants. So it's really important that throughout the year we make that known and help raise the profile. And on this slide, we've got a quote from Sam Allen, the Chief Exec at the ICB, which suggests that the ICB also understands the value of social prescribing. So we've got a lot to get through, and I'm now going to hand over to Simon Bromhead from Ways to Wellness.
Thanks, Richard. Can everyone hear me all right? Nods? Yes, nods, good. Thanks, Richard. Morning, everybody. My name's Simon Bromhead. I am Head of Development at Ways to Wellness. And I'm going to spend the next few minutes talking to you about a pilot that we've been running, looking at how social prescribing can support people with persistent physical symptoms, by which we mean people with chronic pain, chronic fatigue, IBS, those kind of persistent symptoms that people are, many people are living with. Next slide, please, Fran. So just a quick bit of background to us. Richard gave us a lovely introduction, so thank you for that. We're very much about tackling health inequalities, and I think there are a number of dimensions to our work. So tackling health inequalities is very important. Testing and learning is a critical part of what we do. We don't see ourselves as a delivery organisation. Rather, we want to take ideas and we want to test them, and we want to learn from them, and we want to share that learning, critically share that learning with other people, hopefully to influence the kind of wider policy and practice environment. And we've been trying to do that we've been around for a little over 10 years. I've been trying to do that for that kind of period of time. Another dimension of our work that's very important is cross-sector partnership working. So we believe that the voluntary sector has a really important part to play in tackling health inequalities, but we also want to see the public sector, academia, and so on being involved, and want to try and bring those different partners together to have the biggest impact we can. Next slide, please. So this is the Persistent Physical Symptoms, or PPS, project. It emerged because we have a couple of GPs on our board, and they were telling us about the enormous amount of number of appointments and time and things like that that's taken with people with persistent physical symptoms. This is an issue across the entire system, both in primary care, so 20 to 40% of cases for GPs, around people with PPS, 50 to 60% in secondary care. So it's a big kind of pressure on the system. And clinical solutions are pretty widely recognised as not necessarily being the only option, and very often not the best option. But unfortunately, if you're a GP and you've only got 10 minutes to spend with an individual, you might feel pressure to prescribe because you simply don't have the time to go into the detail, those kind of non-medical issues that might be affecting that person's well-being and their health and their ability to kind of manage their condition. So we were really keen to kind of have a look at that. And about 2 years ago, it's just coming up to 2 years, we started a pilot, very small scale pilot, 4 GP practices in the west of Newcastle. 3 of them are in deep end practices. For those of you that haven't come across that before, their practices working in the most socio-economically deprived areas. And there's a kind of network that works together on shared issues. So we started in spring 2024. And one of the things we found as we were going through was that quite a lot of people were talking to us about work. They might have been unable to continue working because of their condition, but they were keen to get back into work, keen to kind of move towards work, volunteering and so on. So in autumn 2025, we saw an opportunity to explore this a little bit more through the North East Combined Authorities Economic Inactivity Trailblazer. So for the last 6 or 7 months, we've been looking at that and looking at how we can kind of take what we've learned and particularly look at that kind of employability angle. So I'll talk to you a little bit about that as well. Next slide, please. So this is, I guess this is just to explain the kind of experience of pain that people have, pain and persistent physical symptoms. I should say that the majority of people are people that have chronic pain. So I may talk about pain, but I do mean PPS. Essentially, what happens for many people is that those symptoms become a bigger and bigger part of somebody's life. And the things that actually matter to them, going out, being financially independent, being able to go to work, being physically active, get pushed out. And so what our link workers are trying to do essentially is to help with the management of their particular symptoms and try to bring in some of those things that matter to people and bring them back into people's lives, and hopefully introduce some new things as well, whether that be, for example, here, volunteering, trying new things. Pacing is a really important thing. So we find that, people with PPS may kind of feel great one day and do a lot of things, but then that knocks them back for a day or two afterwards. So pacing is quite an important thing and something that link workers spend a lot of time working with people on. So the people that we can get referrals from, so they need to be registered with one of our 4 GP practices. They need to have a persistent physical symptom. It needs to be mild to moderate. We don't deal with severe PPS, so mild to moderate symptoms. Sinister pathologies need to have been excluded. So many of these people will have gone through testing sometimes for several years, but no conclusion has been reached or no further tests are needed. And so they're in a position where they're beginning to think about how they can live with their condition, how they can live with their symptoms going forward. And critically, they need to be in a position to feel like they're ready to make that step towards living with their symptoms. And at that point, they're in a good place to be referred to a project like ours. Next slide, please. So this is a slide used by our team around the kind of intervention. And I thought I'd pick out 2 things on this slide in particular. When we set this project up, we were expecting a kind of fairly sort of standard social prescribing approach, really, setting goals, working with people through those goals and providing support where it was needed. And then at the end of that, thinking, did they want to make any more goals? If yes, we would work with them. If not, we would discharge them. And in some respects, it has been like that. Certainly, the general elements are the same, but we have noticed some differences, which I think are quite interesting. So the first thing is, you'll notice on the left-hand side, validated listening. So I'm sure you all know that listening is such an important part of what any social prescribing link worker does. And it's most definitely the case here. The link workers say that sometimes it can take a couple of sessions for people to really go through their story and tell the link worker about what they've experienced. Validation is especially important with this group, though. And, you hear stories about people with chronic pain, perhaps being told by clinicians, it's all in your head. And that's a very, very difficult thing for someone to kind of move on from when they're experiencing pain and other persistent symptoms. So actually allowing people to tell their story and validating that story at the very beginning helps to build trust, but it also, is a really important part of the process for each person we work with. The other thing I wanted to pick out was adaptive repetition. So essentially what we mean by this is that what we found is there's a kind of smaller feedback loop often required with this group of people. So for example, a client might say that they're struggling to sleep. And what the link worker will do is they will talk to them about things that they can do, come up with a suggestion for how they might be able to tackle that. Suggest that they try it for a week or two, and then the next appointment ask them how they've got on. If it's worked, they'll build on it. If it hasn't worked, they'll try something else. Again, not a million miles from what any social prescribing link worker would do, but I think that feedback loop is smaller, and that need for a repetition of the process and building on what's working and rejecting things that don't work is helping people to kind of manage their symptoms better. Next slide, please. So I mentioned the Economic and Activity Trailblazer. So this is funded by the North East Combined Authority. And what we've tried to do here is, as I say, work with clients that are thinking about employment, many of them a long way from employment, as I'm sure you can imagine. Some of them maybe not even leaving home or very rarely leaving home at the point at which we start working with them, but they have employment as a goal that they want to set themselves. And so we wanted to explore that a little bit more. So we set up a test and learn, kind of a pilot within a pilot, essentially, to have a little look at this. These are some of the changes that we've made, mentioned on the slide. So we've expanded the referrals, and we've started working with the primary care network in Northumberland. We've also tried a few different ways of getting referrals, and the one that's working best for us is essentially using the data that the primary care networks, the GP practices have to identify prospective clients and then make a direct approach and invite people to join the programme. So the process that seems to be working best is getting an honorary contract in place with the practice so that the link worker can access practice data, and then working with practice administrators to identify those clients, prospective clients, and then making that direct approach. And we've also established more links with employability services. We already had some, of course, but we've kind of strengthened those, and we see ourselves as working with people furthest from the labour market here. So we actually don't have any targets to get people in jobs, though, as you'll see in a moment, we have managed to get 1 or 2 people into jobs. We want to actually move people to a position where they're better able to access those more mainstream employability services and do that in a sustainable way so that they can benefit from it. Next slide, please. Oh, and the other thing that we've done with with this project is develop a toolkit for employers. So a lot of employers may feel quite uncomfortable about how to deal with this with employees or prospective employees. And so we've developed a toolkit. This is brand new on our website now, with a series of kind of tools to help people to understand how they can best support their employees with PPS. And we've also got some printed materials which should be with us in the next day or two. So do go and have a look at that if you're interested in finding out more. Next slide, please. I just thought I'd give you a couple of slides on the data. So this is 2 of the measures that we've been using. We love collecting data. As I say, it's all about sharing that learning. This is the Wellbeing Star is one of the things that we use in all of our projects in one form or another. So essentially what we do is at the beginning of the intervention, and usually after about 6 months, we talk to people about each of these 8 domains, these 8 areas of the individual's life, and we ask them to score it from 1 to 5. So 1 is not even thinking about it, and 5 is as good as it can be. So by scoring at the beginning and after 6 months, we can see progress, but it also helps us to set goals. And here you can see that we're seeing progress in all of the areas that we're measuring, but particularly around managing symptoms, feeling positive, and also around work, volunteering and other activities. So they're the ones where we're getting the biggest kind of move as people progress through the support. Next slide, please. We've also been using a measure called the Pain Self-Efficacy Questionnaire, or PSEQ. So this is very much about measuring confidence in undertaking daily tasks despite having ongoing pain. So you can see there are kind of 10 questions here, and we're again measuring at the beginning and after about 6 months. And again, we're seeing improvements in each area. The areas where we're getting the greatest movement here are I can gradually become more active despite the pain. I can socialize with my friends or family as often as I used to despite the pain. And I think most importantly, I can enjoy things despite the pain. Next slide, please. Okay, so this is a case study that we've just collected, an audio case study from Sumi, and I think there's a lovely sentiment in here. I think it shows the difference that this project, but also social prescribing more generally, can make for people. So hopefully we can start it now. So there you go. That's just one example of an individual that we've been supporting through this project. So it's been super interesting learning. I hope that's interesting for you guys as well. Just one little plug, if I may, just for 30 seconds. As you can see, we love data at Ways to Wellness, and we're just in the process of developing a new training course called Telling the Story of Your Impact Using Data. It's funded by North Futures. It'll be a free course for everyone in the North East and North Cumbria, some face-to-face and some online available. If you're interested in that, then you can sign up to register your interest at the moment, and we'd love to see you there. Thanks, everyone.
Thank you, Simon. That's really interesting, and we'll share the link perhaps with the notes for that training. That sounds really good. We've got time for some questions if anybody would like to ask anything relating to this presentation. I think with Karen Marshall, would you like to come in?
Hi, thanks. Great presentation, thank you. I'm very interested in the outcome measures. I've seen the wellbeing star before. Is there but not the pain self-efficacy questionnaire? And it looks like there's been some great improvements there. Is there any guidance about the minimal important clinical difference that you need, or is some questionnaires there aren't, and you just hope that they're just getting better and that's going in the right direction? So that was a question I wanted to ask.
I think think there is. Yeah, I think there is what we'll consider to be a reasonable kind of improvement. But I must admit, I don't know what it is. I can certainly find out for you, though. It was a measure that was suggested to us by some. We have a sort of steering group for the project, so it was suggested to us by an academic. I think it was. It's on the steering group, so it has been very helpful. But yeah, I'd be happy to provide a bit more information about it because it's been a really useful kind of tool for us. So yeah, happy to answer that for you.
Great, thank you.
Thanks. Anybody else got a question for Simon? Lisa, you can help me out if I miss anybody.
Can't see any hands at the moment,
Yeah.
Richard.
Well, it gives me time to ask a question then. I'm just interested. Last year, I was involved in an oversight group for a citizens' jury on management of persistent pain. I think I wasn't at any of the evidence sessions, but I believe Ways to Wellness would have presented on that. Is that right, Simon?
Yeah, we were. Yes. Yeah. I mean, it's kind of been identified as a gap, so it's great to have been involved in that. So when we were doing the kind of setup, we looked at the NICE guidance around chronic pain in that instance, and it was the use of social prescribing for people with chronic pain was identified as a gap in people's knowledge. So I guess my hope is that this kind of project actually helps to fill that gap. And yes, we were involved in that, and we're very keen to be, obviously, because it helps to do that kind of influencing thing and hopefully share what we've learned.
Brilliant. Yeah, thank you. Louise, did you have a question?
Hi, so I work as a psychologist in the Live and Well with Pain service in Northumbria.
Yes.
It was really interesting talk, so thank you for that. I was just wondering about how you were kind of distinguishing between what would be like mild to moderate and kind of more severe complex, because I guess we know from Sir Pain you've probably used quite a lot of have quite a lot of fibromyalgia diagnoses and things, but
yes. Yeah, good question. It was actually one of the hardest things when setting up the project to establish how to define mild to moderate. And to be honest with you, in the end, we avoided it. we just kind of avoided it because the question we had to ask ourselves was really, did we need to define it with precision in order that a GP or another clinical practitioner would feel comfortable that they would definitely be able to make that referral and the referral would definitely be accepted? Or was it better to keep it flexible so that the clinician could make a more nuanced kind of decision? And the decision we took was to keep it nuanced. So, and as I say, there were a few concerns that might cause people to be unsure about making referrals. I have to say, I don't think that's come out in practice. I think it has worked relatively well, keeping that sort of flexibility. So no, we haven't put a specific definition. And as far as I'm aware, I don't think we've had a situation where someone's been kind of, a referral's been rejected because we felt that their condition's too severe. So it appears to have worked.
Yeah, no, that's great. Thank you.
Thanks, Louise. Anybody else before we move on?
We've got Benjamin's hand up, Richard.
Okay. Benjamin, would you like to come in?
Hi, Simon. Yeah, it's Ben Anderson from the ICB. Just really interested, I guess, in the use of practices to identify prospective clients and what criteria you had in the search to identify people, and then what the response rate from those that were reached out to were in terms of numbers coming into the service.
Yeah, so we've tried a few different criteria. I must confess, I don't know where we've landed in terms of the final one, but basically because we can look at things like fit notes and things like that, then that's one of the key kind of criteria. Obviously, they need to have PPS as well. Response rate. So when we did when we've done the data-driven one, which has been the kind of most successful. I was talking to one of the link workers a few days ago, and he was saying he reckons about 50% of people are converting once we kind of get in touch with them. So the process we've used is a text message from the GP practice saying you're going to get a phone call, and then the follow-up phone call by the link worker. I should say one of the challenges, I think it's fair to say one of the challenges with the economic inactivity trailblazer is it's funded ultimately by the DWP. So there's quite a lot of form filling to be done when people are actually brought onto the programme. So the PPS project that we had, nice and straightforward to get people on, lots more form filling. And we do know that that's put a few people off. So we were very clear at the beginning that we needed some very clear lines, communication lines about what was going to happen with people's data and that sort of thing. But it's about 50%. Yeah, it sounds like it varies kind of day by day as to exactly how many people kind of get on board.
Thanks, Simon. I'm going to move us on just because I want to make sure we get through everything in the time. But if anyone does have a question, then pop it in the chat and we'll make sure it gets to Simon afterwards. Okay, thanks very much. We're going to now hear from Sarah Penn at Cumbria CVS. Sarah,
Hi,
you okay to? Yeah.
Yeah, I'm great. Thank you,
Great,
Richard.
thank
And
you.
it was really interesting hearing from Simon. So my presentation is going to be slightly different, and that reflects, I suppose, the different nature of my role. I'm not directly involved in the actual link working social prescribing on the front line. My role at Cumbria CVS as Health Partnerships Support Officer, funded through one of the social prescribing infrastructure grants through the ICB, through VONNE, has been much more about that behind the scenes work, improving those links and connectivity between link workers, between the voluntary sector, and between all kinds of different clinical settings. So mine will be much more about those behind the scenes roles. So next slide, please. But I suppose what I wanted to draw out, particularly given the theme of the day, is that kernel of human relationship that is really the building block of the social prescribing model, the social prescribing relationship, is mirrored, and in an effective social prescribing ecosystem, that kernel of the relationship is equally important in all different levels of the system. So between those different services that are offering social prescribing, between the voluntary sector and the social prescribers, between the community and the social prescribers, that there are all sorts of different levels of relationship that need to be mirrored and worked on, that they don't happen without some effort and some time going into that. We've got some photos there from some of the work in North Cumbria doing this work. The one in the top right corner shows one of the events that we held, a Link and Think event, which brought together lots of voluntary sector organisations and lots of different link workers from different parts of our system. So next slide, please. So yeah, just to kind of recap on some of that, those relationships, and we do have that central relationship of the link worker and the client, the patient, the service user, however, the person who needs some support. We have that central relationship, but in order for that relationship to be able to really thrive and make those changes and make those long-term changes, you have a whole series of other relationships that need to be nurtured, really. So between the link worker and those voluntary sector organisations that they're prescribing into, that go on to continue that relationship with the person receiving support, and then how that voluntary sector organisation is able to build the relationship with the person they're supporting. In Cumbria, we have a lot of different people who are doing something that could be described as link working, social prescribing, link working. We take a very broad view of that. So making sure that those people have good relationships and they're able to pass people between them when appropriate. There isn't that kind of rivalry and defensiveness that can occur when you don't have that personal relationship building, when when it is a, you know, an email, or when you don't have that time face to face to actually understand what people are doing and how you can work together. And then I suppose my role as in a local infrastructure organisation as a partnership builder, really. So being able to make those connections across different services. So for instance, and being able to link into perhaps regional and national pictures as well. So some examples of that might be linking up the Ways to Wellness, the space project that Anna's going to be talking about, linking them up with our Barnardo's children and young people social prescribing, making sure that children in North Cumbria are not missing out on something, and yeah, kind of bringing those connections together. And then also, obviously, as a CVS, as a voluntary sector organisation, building those connections with our voluntary sector organisations, and raising awareness of the work that they're doing, championing that, and sort of putting that at the forefront of a social prescribing model. And then there might be other services, you know, it isn't a, yeah, there might be other clinical services, there might be hospital discharge pathways, all kinds of things that could be thought of in a social prescribing context. And yeah, there are just some key elements there that I've found have been really important and kind of need to be stated. It's more than a paper exercise, really. People need time to build these relationships. It's not just about the time between the social prescriber and their client. It's also about the time that that link worker has to actually know what's going on in their community, to build those links with organisations and with the community in general. Trust is so important, not just within, again, not just within the social prescribing relationship, but between all of the link workers, all of the voluntary sector and the link workers. There are lots of different barriers to overcome with that, in terms of that feeling of, you're prescribing to us, we're not getting any of the funding, you're getting the funding, but we need the funding. There's a lot of different tensions and relationships to navigate, really. One of the things that I think is really important about social prescribing and needs to be held on to is that sense of there being some slack. Our health system is very taut. The pressures on clinical services are extreme, and people don't often have the slack in their time, in their day, to actually be able to think in a social prescribing way. So being able to give people that that slack, that extra time, the flexibility in terms of how long they have with somebody, how many times they can see them, what that journey looks like, I think is really important as well. And so, and I think that again leads to that, the importance of having people who are able to take a bigger picture and see what those links might be, see where we can maximise and optimize what we're doing, really, and to appreciate, like you were saying, Richard, at the beginning, to really appreciate and showcase and celebrate the incredible work that link workers are doing in our communities with our most disadvantaged, marginalized communities. So yeah, so all elements of a successful social prescribing ecosystem. So yeah, next slide, please. Just to give you a bit of an idea about North Cumbria's social prescribing context, we have, I've mapped this out into sort of the three main sectors that are delivering this. So the local authority, we have 2 local authorities whose boundaries are different to our health boundaries. So that, again, it creates challenges. We have our primary care system, which sometimes directly employs, sometimes commissions externally, generally through the additional role reimbursement scheme, but not always. So we have those different schemes. And then the third sector, so, the work of social prescribing is really, its natural home is within the third sector, and before it was called social prescribing, the third sector was doing this work. So in recognition of that, yeah, we have our own Cumbria CVS, we have third sector referral coordinators who are able to really link in effectively through honorary contracts with our acute hospital trust and support with those clinical settings, getting referrals out into the third sector. Age UK do such an amazing job with their casework, and they might not be called social prescribers, but they're working in that model, linking out into support and holding people in a space. And then we still have a social prescribing link worker team at Together We, which again was originally supported by Ways to Wellness and has been through many different iterations, but again, the funding is fragile for a lot of these roles. The third sector funding is fragile. The primary care funding is fragile. So I think it's worth recognising that as well, that however much we celebrate this, we need to recognise that that we can't take it for granted. Next slide, please. So in terms of North Cumbria, so over the last 2 years of my role, there have been a number of ways that we've been championing link workers. So through the events that we've held to bring them together, to support them to access knowledge and understanding and relationships with the third sector. You can move on to the next slide, please. We have today published some new web pages hosted on Cumbria CVS, which I would encourage you to go and visit. I think you can send them round. I'm not sure if I embedded the link in there, but hopefully we can send it round. I won't put it in the chat, but we can send it round afterwards. And they just have a very brief explainer about what social prescribing is, how we think about it in North Cumbria, because we do have a very broad and inclusive idea about a social prescribing approach, and what that might mean. What are the key elements of it, how you can get involved. We have some district level role mapping documents that really help set out who's doing what where, and some explainers about why social prescribing is relevant to the voluntary sector. How key that relationship is really. And later in the spring, towards the end of April, we'll be publishing a report, Passion, Connection and Community, really looking at a whole range of person-centred neighbourhood health approaches in North Cumbria. So look out for that as well. And that has a series of case studies, 8 case studies from across North Cumbria, as well as some top-level data in terms of the number of referrals coming in and accepted. And it will also have a bespoke evidence summary from the University of Lancashire, who are really pulling out from the national outcomes evidence the particularly relevant stuff to North Cumbria. So if you move on to the next slide, and I'll explain a little bit more about that as we get to it. It all came from the steering group. So we do have a system-wide steering group in North Cumbria that's been in existence since 2019, and has sort of gone through many different guises, some different names. It's been in all sorts of different governance structures or not. What happened nearly 2 years ago is that in one of the ICB restructures, it lost its home, and Cumbria CVS adopted it really. So it carried on. We didn't want to lose it. And at that point, we had a big refocus event. We brought lots of different people in to really think about what we wanted to do, what our aims were. We came up with those 4 main aims and those 3 main drivers of how we might do that, and what we might be able to achieve. And it has been a real challenge, I think, leading that as a third sector organisation without the governance support behind it necessarily, and kind of constantly needing to fight for that buy-in from our statutory system really, and fight for that recognition. So we've been doing that. If you move on to the next slide. So our report. So the origin of this report came from, in the mists of time, some personalised care funding that was used to, half of it was used to do a survey of link workers in the voluntary sector in 2021. We did have funding to repeat it, but what we decided to do as a system instead, mainly because we knew that the same issues and the same problems were still present and nobody had really addressed them, was to create this report. So really showcasing the work and the passion and that commitment of our link workers here, and to showcase what they were doing. But what we knew was that we didn't have outcome evidence across our system, but we didn't want to discount all of the great national evidence that was that has really emerged over the last few years as to why social prescribing is an effective intervention. So that's where our bespoke literature review evidence summary came in to highlight some of that some of that peer-reviewed evidence that can underpin decision making around social prescribing. We really wanted to build a case for better funding of the voluntary sector in terms of delivering the groups and the activities that are socially prescribed into. And one of our thoughts and aims was around the potential for a shared investment model, which is something that NASP, the National Academy for Social Prescribing, has championed, and there is work going on nationally to look at how that might be achieved. And the basis of that being pooled investment from across philanthropy, statutory services, to kind of create a fund for those delivery organisations to actually be able to create a sustainable model of social prescribing activities and delivery. Next slide, please. And I suppose as we've been writing that and commissioning that and creating that, it's really brought up a lot of questions about who we are talking to, and the last year has been a a difficult space in terms of who we're talking to, who those key people are in commissioning roles, in strategic roles. What is the right language? We seem to have seen a shift away from a social prescribing language towards neighbourhood health and community well-being. And so we're kind of working with that, recognising that, understanding what the words are that we need to use, and what is it that we're trying to achieve. Is it about protecting the system that we've got at the moment? Is it about advocating for a different system and something that is more rounded in its approach to link working and then the delivery? I suppose what I wanted to kind of end on are the themes that are coming out of our case studies. We're pulling them together now, and they range from a relatively light touch style approach, maybe telephone support, signposting, right up to in-depth 6-month coaching with people who have really complex issues: homelessness, criminal justice system experience, addiction, and everything in between. And I think for me, the title of my presentation and the title of our report, that passion, and that is what really comes out first, is the link workers' commitment and their willingness to kind of connect with people and then work with them until they can find that solution. So that passion is really coming out. I think the importance of that, developing that relationship with the person they're supporting, taking the time to build trust, and trust doesn't come easily in a lot of these environments and circumstances. Building that trust, and then the importance of holding somebody through all of the other different services that might be involved, the referrals that you're making. It's not a paper exercise, it's not an electronic exercise, it's a human relationship that holds somebody through that access to other support, through perhaps a more empowered approach, through better links into their community, and a more sustainable health and well-being situation going forwards. And coming back to where I started, whilst the human relationship element of the link worker and the person they're helping is reflected in the relationships that kind of sit behind that within the system, I think that idea of being held is important at all levels as well. So we need to hold the people who need the support, but also we need to hold the social prescribing system. We need, and I think I felt that so much in my role trying to hold it, that we need a system that appreciates, understands, and kind of makes it feel loved and appreciated, because these are challenging roles, and they need that to be able to flourish and retain their staff as well. It's a tough job that we're asking people to do. So yeah, that would be my final plea for that recognition and that sense of being held and being loved, really. I think that's my last slide. Oh yeah, so I do have a link to our webpage. It's live today. Go and have a look. And if you want to know more, if you want to be on the the list to receive our report when it comes out, we'll be going on about it a lot. So don't worry. I'm sure you'll know. And yeah, thank you for inviting me to speak today. I don't have it's always a harder task talking about infrastructure than than the delivery. You've got a lovely video now though to make up for it. So thank you.
No, thank you, Sarah. That was fantastic, and you've really drawn out a lot of key themes, really important themes, linked to the things in the system that make it work, that make it effective, and we really have to be conscious of those and make sure that we don't lose those as we change systems and become more efficient and digitize and things like that. We need to hang on to those relationships and the trust and the kindness and love. Let's not shy away from those things. Do we have any questions for Sarah? Yeah, Ben, do you want to come?
Yeah, hi
Ben?
Sarah, really
Hi, Ben.
good presentation. And I'm just thinking, as the sort of ICB goes through its transition, shrinks in size and capacity, but moves into that strategic commissioning role, something really important for me around, what is the role of a strategic commissioner in supporting that thriving social prescribing sort of system? I think your report will be really useful for us to that. But any sort of key things you see as being needed from commissioners?
I think being explicit and recognizing the role of social prescribing system and championing it, I think that is key. Because it's sort of written in between the lines of a lot of things that have come out in the last year or so, and that creates a bit of nervousness about whether it's going to be, whether it's going to be discarded or it's going to be shifted or the money's going, so I think being explicit about it being valued is really important from that strategic point of view. And I think there needs to be that recognition that it's going to look different wherever you are. There's no, that there needs to be that flexibility. But I think encouraging, as those neighbourhood health work streams develop, encouraging those to think about how they are tapping into the social prescribing workers, the social prescribing infrastructure that's already there, how they're supporting that and how they're learning from that. I think, making sure that we don't discard what we have built in favour of something new would be another key ask that I would have.
Yeah, and I'll throw in something as well. I think also longer term investments. I think when you're trying to maintain and build relationships, it's not helpful if every year the workforce is stressed and moves around and job insecurity, and that's not helpful to the system as a whole.
And I don't know if there's where the role sits in terms of the accountability for, say, GP contracting, in terms of the DES contract, because we've seen a lot of different different PCNs rolling back their social prescribing or decommissioning elements of it, without a lot, what seems to me, and that I might be wrong, without much oversight in terms of that strategic view. So I think it would be, that is a role that needs to happen somewhere, and be interesting to know where.
Thanks, Sarah. Thanks, Ben. I think I heard that Joel was wanting to come in.
Hello, yes, thanks for that,
Yeah.
Sarah.
Hi.
It's not really a question, just really to get the offer my support and agreement. We've got some, so around at North Eastern Cumbria, we've got some funding through VONNE to look at social prescribing and try to create referral pathways in the Ashington New Biggin area of Northumberland. And I think we're not having much success. We are encountering lots of obstacles and barriers, but I think what we have found is exactly what you've said. The link workers are absolutely key to form that relationship with the patient, but also the voluntary organisation that can provide the activities. and to act as the sort of go-between or to introduce them. And I think, yeah, social prescribers knowing what's going on in their areas is also key. And that's that's the main obstacle I think we found, is we trying to get that rapport with GPs and their social prescribing teams and social prescribers. That's the difficult bit. They're very busy, don't have much time, and essentially we're cold calling them to say, hi, we're here to help. And they're probably thinking, what's it going to cost me? You know, they're asking the questions. So that it's kind of getting that introduction to the GPs and working with them, we found quite difficult as well. But I think speaking to patients, a big concern being a rural area is transport.
Yeah.
And it's not just cost, it's the access. So we spoke to patients that are in mobility scooters, they just can't get on buses. Trains can be problematic. It's probably only suitable taxis that are going to help them. So yeah, it's cost and access to public transport is a huge issue as well.
And that's absolutely, you know, that's a huge thing in Cumbria, obviously. And it's, yeah, and it is a massive barrier. And whilst you might be able to get transport to a hospital appointment, social prescribing is reliant upon people being able to access wellbeing support in the community. And if that isn't equally supported, then, you know, it isn't social prescribing.
Yeah, and transport is something that comes up in a lot of health inequalities work and those access issues. And it's something that I know that in a separate piece of work that VONNE's doing with the mayoral authority in North East, are looking at the issue of access and public transport. So hopefully these different parts of the system will be able to kind of do some joint working to resolve some of this. Conscious of time, so we'll have to move on unless there's any burning questions. But if you wouldn't mind putting them in the chat, that'd be great. And before we have a quick break, we've got a very short video to show you. I'm going to let Jen introduce it actually.
Yeah, okay. So Carlisle Youth Zone is one of the 6 funded projects that VONNE has been overseeing. Now, unfortunately, they weren't able to take part in the video, The Power of People, that we're going to show you after the break. But just to give a nod to the amazing work they're doing, we've got a lovely performance from some of their young people that they've created. So, thanks, Fran.
The feeling that I get when I try something new, but when I can't do it, I end up feeling so blue. Being with the people you like makes you feel safe, but the peer pressure can also get in the way. Memories don't fade, so much to look back and forth to the future. The past is now gone, facing challenges, trying to stay strong. Something to remember, something to forget. Nothing lasts forever. I wish we never met. Laughs and jokes that bitter, wasting almost time. All those memories, they fade away.
Stabbing sirens, seeing all the police. Anything can happen, my mind's out of ease. Robbings, stabbings, grew up round gangs, just a young manny boy. Hearing all these bangs, through dark north, my mind's back at ease. Starting to notice a lot less, please.
To remember, something to forget. Nothing lasts forever. I wish we never met. Laughs and jokes, they're bitter, wasting all this time. All these memories, they fade away.
Fabulous, thanks. Thanks to the participants there from Carlisle Youth Zone. And we'll hear more about the other projects after the break. So if we could be back for 10 past, please, that would be brilliant. Okay, I'll make it 10 past, so I think we'd better press on. We're running a little bit behind. I think one or two people might be struggling with some of the video content. We will be sharing the links as part of the slides, so hopefully you'll be able to watch those and after the session. Okay, we've got now time for us to share another video, and Jen's going to tell us a bit about that.
Thanks, Richard. So there are 6 funded social prescribing projects that we've been supporting at VONNE, and these are funded by the ICB. And then as that funding has come to an end, we wanted to create something as a legacy, really, to showcase some of the amazing work around social prescribing happening across the region. So this video was produced together with Digital Voice, and I'm biased, but I think they've done a fantastic job, so I really hope you enjoy it.
VONNE exists to support and promote and advocate for the voluntary community and social enterprise sector, and that sector plays a big part in delivering health and wellbeing services to communities across the North East and North Cumbria. We need to make sure that we've got a strong social prescribing system that's going to support the move towards neighbourhood health, and we need support for the social prescribing workforce to make sure they can deliver and are aware and have the skills to do that.
Social prescribing is non-medical support around things that affect health and well-being. We support people who've been through a lot of different things in life. Everybody's journey is a bit different. It's very challenging at times. Sometimes you do meet people when they're at the lowest points in their life, and you can help them make a plan and support them to get to a place where they want to be.
We've got a range of projects ongoing. So we've got International Community of Sunderland, West End Refugee Service, we've got Groundwork North East, Edwards House in Gateshead, and Men's Pie Club.
I've been a social prescribing link worker for around 5 years now. Today I have brought a patient along to the Men's Pie Club. It's something that we've worked on for a while, building up the patient's confidence to come here today. So I was just coming along as a friendly face to support the gentleman to this session.
Men's Pie Club is a social enterprise that gets guys together. It helps guys tackle mental health struggles. Guys can come in, have a cuppa, make a pie, have a chat. Local guys making pies.
At first I was in a dark hole, so I was suicidal, but Pie Club made a massive impact. Came back every week, plucked up the courage, and here I am today. Now I'm a volunteer. I love every minute of it.
A social prescriber can sit down with the person and look at what's going on in their lives, and it might be stresses caused by things like poor housing or insecure work or isolation that's causing that person to feel unwell.
One of the biggest problems that we find when people first enter the UK is social isolation and loneliness. Quite often we'll get people that come to us that don't understand about going to the optician or the dentist or whatever that may be, and we signpost people. We also do a weekly welcome. We cook meals together. That's always a really, really nice time to chat. Adult colouring in and stuff, you know, just giving people something to do with their hands so that if they don't want to talk and they just want to be around other people, it's not awkward.
I feel happy to meet new people, learning new things, and also maybe share something that I know.
When you come here, it changes your perspective. Like you meet friends, you meet different people, you create friends, and in my house, I just feel like, you know, I'm just alone and the world is not with me, but like here, I see the world around me in different perspective with different people.
Social prescribing has made a huge difference to the people that come to us. It allows us to really focus our groups, to listen to the refugee community, to really hear them and understand exactly what they need, exactly what barriers they are facing, what mental health problems they've got, but in a safe space.
Often people in marginalised communities find it hard to engage with services and often have the highest levels of health inequalities. So we're trying to address that with these projects.
ICOS has been around since 2009, and we support migrant people in Sunderland and the surrounding area with accessing benefits, accessing healthcare, accessing services, but also helping them to integrate within the wider community and providing activities just to make sure that they are part of Sunderland.
We came across people who actually were scared to try new things, and they finding out that with the small groups it's much easier.
It's a community where different people come together and get to meet new people, gain new experience, immigrants, people, everyone. And it's a really welcoming place to be.
As immigrants, sometimes it's very difficult to hook up with people. The social life is not that easy like in our countries, and this is a good opportunity for us to go out with people and to socialize and have some fun.
By socializing, you get access to opportunities, you be able to share ideas, rub minds, and you're just happy.
And most important, of course, I feel safe.
Yeah.
You know, to walk together with a group of people that we know.
Yeah.
Social prescribing helps tackle those root causes. It's part of that left shift that the government wants to see towards prevention, and it can reduce things like GP visits to hospitals, so it can save the NHS money, but it does need investment.
Today we are in Ashington Community Woods, and we are with a group of volunteers who are here every Monday, and we're just tidying up some trees down the side of the old railway line that runs down here. It gets you outside, gets you some fresh air, a bit of exercise, and also getting to learn some new skills.
Yeah, it keeps me fit. I like to think of it as a green gym. You know, get a good workout once a week at least, get my heart beating.
Really, it's just to make it a nice place for people to come, to enjoy, to walk the dogs.
I just love it. I just love outdoors and trying to help people, trying to keep things tidy and clean.
Social prescribing is a pathway that's been set up recently for this group, so they can come along and then maybe they might want to give a little bit of their time to the project, and that's the stage that we're at basically, where we're welcoming people, but we need a link worker to sort of hold the hands of people to bring them here, because I think peer support is so important.
Just felt so welcome, and I would really love anybody else to get involved if they would like to give it a try, because you just never know, it might change your life.
We're off to Talking Marrows after this, and it's going to be over at the community centre in Hurst.
Talking Marrows is about being there. So being there for each other, basically. That is all it is. We get together, we meet, we have tea and coffee, we chat. Anybody's got an issue, somebody tries to help them. If we can't, we'll look further afield.
I was at the lowest point of my life and got referred through my doctor, my GP, because of my depression, that, you know, when my bereavement. I regarded them as my second family because they helped us through with a lot of stuff.
Isolation's a huge factor in making people feel stressed and unwell, and these projects can build people's confidence and their resilience and get them more connected into the community, and therefore able to access more support that's going on in their community.
Tea and Toast runs here at Reckitt Family Hub every Friday morning, 9:30 till 11:30. People come along, it's encouraging them to talk and socialise with others from the local community, and it also gives them a chance to ask advice and support. Everyone's just happy to see each other, and it's really nice.
It's helped a lot, yeah. I feel a bit more better where I'm living now, because I've met people near where I live.
You're getting out the house, you're getting ready, you're talking to people, you can talk to people about the problems that you've got, they're talking to you about their problems.
It's helped me with my confidence, my self-esteem, building my relationships up, and obviously my overall well-being, whereas before it was just shot to bits.
We've got community development workers and we have youth workers. And then our other arm is the social prescribing arm. We link the people with community resources.
Emotional well-being is where we provide the most support, and it is where we made the most impact as well. And just making someone feel better, hey, doesn't cost much.
The Hey tool, which is, it's got all the items on there, so it's anything from money, housing, friends, family, emotional well-being, physical health and social connections, and employment, education and volunteering. So we cover all of those in our assessments to find out what's most important to that patient.
So we really want something to help our patient to say, hey, this is one thing I want first. I want to deal with this first. And it had to be from them, because we want them to have the ownership of whatever plan we come up with.
It's been a godsend to me. I mean, I would have been just sitting looking at four walls basically on a Thursday.
It was my safe space back in the day. It was the only place I ever went. And obviously through Edbat, I have managed to progress and I am working full-time now.
It's just been absolutely amazing for them coming in. It's been a really positive outcome for the local area.
And the impact of social prescribing is huge for individuals and for the health and care system. So it will deliver improved health and well-being, it will reduce health inequalities, and it'll save the system money and resources in the future. Thanks, Jen. Fantastic video, and those themes coming through still about connection, about providing safe spaces, giving people time, getting people linked into their community, and the difference that can make is huge and shouldn't be underestimated. Right, we have to press on, time is against us. So I'm going to invite our next speaker, who's Dr. Anna Basu from Newcastle University, and is going to talk to us about social prescribing for children and young people and their families.
Thank you very much. Can you hear me all right? Yeah.
I can.
Great. So yeah, it's a real pleasure to be talking on National Social Prescribing Day, the power of people. I've got two people on the front of my slide here who are two link workers that work in our project, Fliss and Lauren from Ways to Wellness. And really, this is just to sort of describe how link workers can really transform help for children with chronic complex needs and their families. So just onto the next slide, please. So what I'm going to cover is how social prescribing can help children with complex needs, which is a little bit different from some of the other settings that it's been used in. Why we need to bring in a family-centered approach rather than focusing on a single client. Why we need this in the hospital, a little bit about the Space Social Prescribing Service that we set up at GNCH, and some of the evidence that we've got of the benefit of this service and where we're going next. So then just on to the next slide. So I mean, I suspect preaching to the extremely much converted, but yeah, so children do benefit from social prescribing, and there is evidence to show this. There is slightly less evidence than there is for adults, just because there's been fewer social prescribing schemes for children, and also there's just been less data collection for evidence, but it's all showing it's going in the same direction. So there's the same issues. There's loneliness, there's mental well-being, and there are also financial benefits of using this kind of scheme. So the group of children, I'm a child neurologist at Newcastle, and I work in the university as well. And so the kids that I see are children with chronic complex medical needs. They spend a lot of time in hospital settings, either as inpatients or in an outpatient setting too. There's a lot of literature showing that high medical need is associated with high unmet social need. And this is a group of children that, it's the 5% of hospitalized children, but it's 50% of the hospital healthcare costs for children. So it's an expensive group, and we do need to think about, we're putting a lot of money into supporting the families. Are we doing things in the right way, or could we use social prescribing, and would that be more cost effective actually for some of this stuff? We do need to rethink how we're supporting the non-medical needs of this group, because there are a lot of needs. So just moving on to the next slide. And it kind of makes sense. Why do we need a family-centred approach? Because children with medical complexity need to be supported a lot by their families, even when they're a bit older. So young children need a lot of support, but children with medical complexity continue to have high support needs, and they need to be supported by families who are in a position to do that. But the families of these children often run into financial difficulties. Maybe one parent has had to give up their job to look after the child. A lot of them have challenges with unmet non-medical service needs. They have challenges accessing non-medical services. And also, it's a very difficult situation, obviously, for families to go through. I mean, sometimes, your child has acquired a new and life-changing disability, and trying to figure out what to do on the medical side and the social side and manage your own health and well-being, I mean, is a nearly impossible task, and people feel very overwhelmed, and they really need support. So just moving on to the next slide. So why should we start social prescribing from within the hospital? I mean, I think the answer is because we're trying to do stuff that's near to, we're trying to sort of, it's the same reason why we're looking at focusing on the community and NDTs, because actually what we're trying to do is bring support to people where they are and where they need it. But one of the places where people are and where they need it is in the hospital. So you need to be able to support people right from that point as well, because otherwise you're just delaying the onset of support. And there, if a child's been admitted with a new life-changing illness and has gone to intensive care and is coming out and into the ward, they haven't got community support in place. They've got nothing in place, and the families need to start right from scratch. And so it makes a lot of sense to crack on and get some support in to speed things up and to prevent any kind of decline as people have to sort of start to embed into community services and figure out what they need to do. So this is really just about making every contact count, preventing people having to wait and having to travel. If they're already in the hospital and there's a service there, that is very efficient. So just moving on to the next slide. So based on having seen a lot of children and families in situations where they clearly are in need of more support than is available, we set up a service at Great North Children's Hospital, and it's called Space CYP, which is Social Prescribing and Community Resources for Children and Young People. It's the first two phases of this were funded through the Newcastle Hospitals charity, for which we're very grateful, with support from Ways to Wellness, who you've already heard from this morning, both financially and also sort of practically thinking through how to make this work. And then we've done an evaluation of it through Newcastle University with some support from the NIHR ARC link. So it's basically supporting children with chronic complex conditions and their families to be helped by link workers who meet them or referred these families right from within the hospital, but then continue to support them beyond hospital discharge into the community for around 6 months, sometimes a little bit longer. So we started off in August 22. Well, the service opened sort of after a lot of preparatory work. And we started off looking after children with neurodisabilities, because I'm a neurologist and this was an innovative thing. There wasn't really another example to go off, and I just needed to do something that I knew. So we started off supporting children with neurodisabilities who were inpatients and their families, and found a wide range of unmet needs, financial, social, emotional, and so on, in all family members, including siblings as well, actually. So we mapped out the unmet need. It was reduced. We also did a social return on investment analysis for a sort of subgroup of 18 families where we collected an enormous amount of data in detail. And we were able to show that if you invest £1 in the service, you get £2.75 of social value back for that pound. And we've published that paper and described the initial service. And I'm really pleased with that because it's very clear the value of that. And then we after the first sort of phase, when we got extension funding, we listened to what people were saying, and other groups within the hospital were saying, well, look, it's not just neurodisability where this is needed. Other groups of children have chronic complex needs. So what about kids, who've had renal transplants, kids who have immunology problems, and so on and so on. So we sort of broadened it and thought, well, yeah, actually it's the same kinds of needs. And so chronic complex needs. And then also, rather than just inpatients, and we extended to day case attenders, because against the same model, people are sort of hanging around in the hospital. There's a bit of downtime. There's time to meet a link worker, do those assessments and build those relationships. And then also, we were still doing a bit of, test and learn kind of approach here. So the other thing that we introduced was like a brief intervention category, because we sort of realised that there are families where, actually they might not need 6 or 7 months of input, or it might not be practical to do that because they live a long way away from the hospital, and it's not really possible to offer that kind of outreach extension over such a wide area, but actually a brief intervention. So doing assessment and doing some sort of tailored thinking about what could help to start people off, and maybe trying to connect them up with something local. So we added that in. So we are now in phase 3, which started we're nearly at the end of the first year of phase 3. We've got 3 years of funding, which is competitively acquired national funding through the NHS Charities Together Innovation Fund and the Legal and General Health Equity Fund. And we have extended, we haven't made so many changes this time, but we've extended the age range a little bit up to just under 18 years. And we're just continuing to gather more data to continue to show what we're doing. So on to the next slide, please. So I think this will probably be very familiar to everybody. So essentially, it's a referral system, a holistic needs assessment, a co-creation of goals to address those unmet needs. And this is really important. The agenda is very much, okay, so what would you like to work on? What is the thing that matters most to you? And then saying the link workers have become quite specialists actually in managing this group, and they go, from our experience, families in these kinds of situations have found these resources helpful, and so on. So, and then support if needed to connect up with those resources, and then follow up. So it's a kind of hospital to community. There is a left shift in there that takes about 6 months to then generally sort of have people in a better position and a bit more embedded into the community, and then sort of discharged, and so that new cases can be picked up and supported. So then next slide, please. So this is just, I'm just going to go through a few cases because sometimes it's a bit hard to know what we actually mean by any of this, and it's much easier sometimes to have an example. So this is one which are called the deep clean, and this was a family where a child had a bone marrow transplant and so was immunosuppressed, and there were other issues to do with health and mobility and language issues. They didn't live in very good accommodation. There was damp and mold, and you can't go into a house with damp and mold. If you're immunosuppressed, you're going to get a fungal chest infection and get really sick. But it wasn't possible to actually find a solution for getting rid of the black mold because nobody was going to foot the bill for actually getting this sorted out. And at the time, because there has been helpful legislation brought in place that can address some of this now, that puts a requirement on landlords to sort out things like black mold, but that wasn't in place at the time. So one of our link workers got involved and was able to work with other organisations to sort of make sure that there was an assessment of the house, that there was funding from it. So there's a little bit of support fund money embedded within the service, because there are often little things that need a bit of money to make a big difference, and so factored into the service there's a little bit of funding to support that kind of thing, which is really important. So there was a family support fund that was used to get a deep clean sorted and to provide some cleaning materials for the house and some other things, because being stuck in the bone marrow transplant unit, I mean, people do a lot of things to make that environment as good as it can be, but it is isolating. So finding some things for that young person to do while they were in the bone marrow transplant unit, and signposting to activities for the siblings. So lots of things were done by the link workers in this space pilot team. One of the really important things is that this child got home way earlier because they were stuck in hospital with this and they couldn't get home. And it has been, there have been other cases where a child has been stuck in hospital for months because of this issue. And so getting somebody home and counting up those bed days and thinking about how much you can reduce the per patient costs. I mean, there was a massive cost saving, which was, way more than the total cost of delivering the whole service for a year. So this is in line with the NHS kind of 10-year plan: sickness prevention, hospital to home, cost savings, flexible patient focused support. So this is a case that I think that the team is really proud of and really should be as well. So then just moving on to the next slide. So this one, again, this fits in with kind of rural themes. So this one's the rural refrigerator. Which I just like to give these things titles. But so there's a teenager who is unable to take food through the gut and has to have everything IV using a special solution that has to be stored in a medical fridge. And they have 9 bags at a time, £1,000 per bag, because it's bespoke, sort of specially made up solution. And they live in a rural area and they keep getting power cuts. And so if you have a power cut and your fridge is full of TPN, I mean, one of two things is going to happen. Either in the middle of the night, you're going to run out of energy and all of those bags of TPN are going to go off. And in the morning, your child has to be taken to hospital to be fed. And you've just lost £9,000 worth of medical, supplies, or you realise that it's gone off, and then you have to wake up in the middle of the night, stick your kid in the car, stick the 9 bags of TBN in the car, and drive around the rural community till you can find somebody who can put those things in their own fridge or whatever what you're going to do. So this is crazy. So one of our link workers was able to kind of basically sort this out through finding solutions to energy, and again finding an uninterruptible power supply that gave the family a bit more time to get this kind of thing sorted. So again, reducing NHS waste, reducing unnecessary hospital presentations, very sort of tailored problem solving, really thinking, how do I solve this specific problem that hardly anyone else has got, which is really impressive. And then just onto the next slide. This is I guess in a way a more familiar kind of link worker kind of sort of thing to do, if you like. So this was that but again, this is 2 twins who had spent the first 18 months of their life in hospital. So this mother had felt really disconnected from usual support through parent groups, being in hospital all the time. And the link worker helped the family to go to a group, took them to the group, found them money for things and some financial support, and just provided solutions that us as clinicians wouldn't really have necessarily been able to do, because we're just we just know different things. And so this family was hugely helped by that support. So I need to crack on. So next slide, please. So this is just very briefly. So we've already talked about the support star and the wellbeing stars. So this is the one that we used in our studies, and it is sensitive to change. And we've shown in space 1. I've also got the data for space 2, which I haven't shown here. But across all domains, we're seeing there's an increase in well-being. Essentially, there's a reduction in unmet need. And important goals are identified. Almost all of the goals are met. At 96, something like that, % of goals were met. And so it's effective. And then just moving on to the next slide. This has been quite an impactful project. We got mentioned in the NIHR annual report for last year for the evaluation. It's supported 340 individuals since the beginning for an average of 7 months with high levels of engagement. We've had national media coverage, and we're the case study in the NASP Vision for Children. Connected to Thrive. So it's doing something worth doing. So on to the next slide, please. So these are just to show you that there is a web page on the Ways to Wellness website describing the space pilot, and if you scroll down on that, you'll see some videos with testimonials from parents and link workers and so on, and you can see the link to the published paper. And then just next slide, I'm nearly done. Yeah, so the vision is really just that, you know, all children's hospitals in England and ideally all children's departments would be able to offer this kind of holistic support for children and young people using this model. And this was a quote from a parent, because there are these times when these things happen where you just don't know where to turn, and we don't want that for families at all. We want to be able to help them. So my last slide is just really to say thanks to all the people, because I really did, you know, there's a lot of people doing this, a lot of funders, and you know, just hoping we can keep going with this and get on to the next stage. So thank you very much for your time.
Thank you, Anna. That's great. Really interesting and really helpful learning in there for other services and for the system overall. We've been talking to people about patients coming out of critical care and how they can be supported through social prescribing. So I'm sure they'd be very interested to talk to you. We've got a little bit more to get through, so I'm going to suggest that we crack on. If you do have a question for Anna, then please put it in the chat, and we will make sure that she sees that. Thank you so much. So we didn't want to finish this conference without hearing from a link worker. So I'm really pleased that our friends at Teesside Mind, who provide social prescribing services in Middlesbrough, agreed that Julie Sinclair Day, one of their link workers, will have a chat with Lucy Cushley, who's their social prescribing service manager, and really about the role and the important factors in there. So are you okay to take over now, Julie and Lucy?
Yeah, lovely work, Richard. Thank you.
Brilliant.
Oh, hello everyone. I'm Lucy. I'm a service manager at Teesside Mind, as Richard's just introduced there. It's lovely to have the opportunity to join the conference today and to talk about the work that we deliver in Teesside. We deliver social prescribing, and we work in partnership with 22 GP practices across the area. And I'm joined by my colleague Julie.
Hi, my name's Julie, and I work in central Middlesbrough with about 6 or 7 different GP practices, and I've been working as a link worker for 5.5 years, nearly 6 years actually. Yeah.
Thank you, Julie. So we'll be sharing our insights into the value of social prescribing and the difference it makes to people from the perspective of a social prescriber, which is Julie today. So thank you, Julie. Can you start, Julie, by please sharing what you enjoy about your job as a social prescriber?
Well, there's a massive variety in my job. No 2 days are the same. I think one of the things that I love most about it is it is an enormous privilege to be trusted and have people share their stories with us. It does feel like that's incredibly special, and to be trusted to walk with them through what might be a very difficult part of their life. And you know, we work with all sorts of people, so there is incredible variety to that. We work with older people, we work with people who might have been involved in the criminal justice system, or people that are struggling with substance misuse, or people that are feeling lonely, and that's across the age range from 18 upwards. So that's really varied, and on a day-to-day basis I can be in a safeguarding meeting in the morning and doing at a knit and natter group in the afternoon, so that's fantastic. And you know, I never stand still. It's, yeah.
Thank you, Julie. How does your role, how would you describe your role makes a meaningful difference to people?
Well, I think it kind of goes back to something Simon was saying about when people are facing some kind of adversity, and he was talking particularly about pain, how their lives can shrink a little bit and they lose sight of what they were able to do before and what they enjoyed before. And that can be, that sort of shrinking down can be as a result of chronic pain, or it can be a result of a bereavement, or becoming homeless, or losing a job. It can be for all sorts of different reasons, but people kind of lose sight of, I used to enjoy this, and I used to be able to, have relationships with these people, and that shrinks down because they're just coping with that particular adversity. And I think it's really helpful to be able to get alongside people and remind them of their strengths, and remind them that they actually have some, they have the power to change their own, to improve their own well-being. And it's not up to somebody else writing a prescription or dictating to them what they think is the best thing for them. It's up to that person to sort of recognize that, well, this is what I want and these are my strengths, and have somebody support them with that, really. And it then, the sort of meaningful difference comes from the fact that they are choosing their goals, they are identifying their strengths, and so it is more meaningful to them. And so any change that they might make is likely to be more sustainable, I think.
Great, thank you. How would you describe your role differs to that of a clinician? What do you think the role of a link worker offers that clinicians possibly don't?
I think the most important thing, and a few people have touched on this, is the time that we have. I think Sarah referred to it as a bit of slack. So we do have an opportunity to sit with people and give them time to tell their stories. That can't be done in a 10-minute appointment, and sometimes it can't be done in an hour-long appointment. You need to be able to build that trust, to allow people to really reveal their vulnerabilities, and that doesn't come immediately. And sometimes people can come in with, well, my problem is my neighbours, and then after you've been talking to them for a while, it's actually, is it the neighbours, or is it the fact that you're struggling to put the heating on, you're struggling to pay for the shopping, you're struggling through pain? Are there other things that we can tackle, rather than sort of pinning it all on the neighbours? And that only evolves that picture of somebody over time, and with that trusting relationship. And I think clinicians don't have that luxury of time in the same way that we do.
Thanks, Julie. I know in Sarah's presentation, she talked about that connectivity of the link workers, the voluntary sector. Are you okay to talk a little bit about that within your role?
Yeah, and I think that's hugely important. And we are very lucky to be part of an organisation that's well recognised in the local area, not only by individuals, potential patients, but by other organisations. So we do talk to each other. And I think, one of the advantages that we have over clinicians is that we're right there embedded in the community, and things change on a daily basis. So services and groups pop up that one week that might not be there 6 months later. And it's really important that when we're helping people to engage and connect with these organisations and activities, that one, we give them accurate information, and two, we give them the support to get over the doorstep, because for a lot of people, that is the biggest step that they will take, is just getting out of the door. And if they've got a link worker by their side, that makes it so much more doable and so much more realistic. So yeah, being already embedded in the community is a huge advantage we have over clinicians. I can give an example of that. Some of our work is very complex and takes place over a long period of time. Some of it is really quick, and you might signpost somebody to an organisation like welfare advisors for a benefit check. And I can write that down on a piece of paper and give it to a patient, but actually being able to talk them through, well, if you phone this number, you'll speak to Brian, and Brian will give you an appointment at one of the community hubs that is nearest to you. And then you'll be able to go and meet him, and he'll sit with you and he'll go through the forms that you need to complete, and he'll help you with that. That's much more meaningful than saying, oh, this person can, if you phone this number, they'll help you complete the forms. It's only a little difference, but it makes a massive difference to the person hearing that information. And of course, you know that's a very simplistic example of the difference that we can make, getting alongside people, knowing where we're referring people to. But it sort of grows from that, really. That's just the start. You know, another way that we can connect people is by advocating and brokering for them so that they don't slip through the gaps. It's very difficult to know what is out there and what you're entitled to or what you should expect. If you've been, you know, either disconnected or isolated for a long time, or conversely, if you've been having a fairly straightforward life and employed and in a, you know, supportive relationship, and that all suddenly breaks down and you've never had to look for support elsewhere, those are two circumstances where, you know, having a link worker is really, really helpful.
Thank you, Julie. And just lastly, are you able to share an example of where you've worked with someone to see the power of change in somebody?
Yeah, definitely. One example, very straightforward, really. And met an older lady who had been bereaved. Her husband had died a couple of years before I met her, and her life had become, you know, she found it very difficult to leave the house. She felt very depressed. She felt very lonely. We worked together. I went to see her for a couple of different appointments to do an assessment. And through that assessment, she identified that she just wanted to feel useful and she did want to feel more connected. She was engaging with her local church, but that didn't go beyond sort of attending services, really. And so we looked at that and found that actually they ran a food bank. So she was very keen to get involved with that. And I was a little bit, oh, I'm not sure how you'll feel about getting involved with that. You know, a lot of people are in very distressed and distressing situations when they have to go to a food bank. But no, she went ahead, and she's now helping at every food bank session by welcoming people and making tea for them. So she's getting out every week, a couple of times every week. She's more connected with the church. She's connected with the other volunteers that work there, and she really enjoys it and has said, you know, thank you. I would never have had the courage to get over that particular threshold without somebody at my side. So yeah, that's a little picture of what we can do.
Lovely. Thank you, Julie. We'll bring it to an end there. I'm aware we are tight on time as well. So if anyone's got any questions, happy to pick them up in the chat or through Richard. I'll hand back over to you, Richard. Thank you.
Thank you both. That was really, really insightful and interesting and great examples there, which kind of resonate, I think, with some of the things we've already heard, that connection. And we saw that that example that you mentioned, Julie, we saw that in the video with it, you know, a link worker bringing a patient to Men's Piped Up, just to help them that first visit, to build their confidence, get them connected. So powerful. Right, thank you very much. We are running short of time, so I think I'm going to have to move on, because I know some people will have to leave for other appointments, that's fine. If we will probably overrun by 5 or 10 minutes. If you can stay with us, that'd be great. If not, you'll be able to see the end on the video recording. So I am going to carry on. So looking ahead at what we have in store for the programme. First of all, thank you to all of the speakers so far this morning. Your passion and insight has been great and really kind of helps illustrate why we need to keep working on our programme. So I'll just explain a little bit about what our plans are for the next year. Next slide, please. So we have these 6 projects which are heading towards the end of their work. They'll be completed during March and April. We'll be working with those projects to look at what learning we can take from those and what legacy. They will all have lasting impact on both the organisations and on the service users. So we wanted to capture that and share that for the benefit of others. Unfortunately, we don't have funding to start any new projects next year. That's not something we're able to do. But hopefully that's something that might develop in the future. Next slide, please. So our aims going forward, we do have some funding to continue this work thanks to the ICB. And what we want to focus on is these 3 key aims. So strengthening the social prescribing system and the new neighbourhood health approach. We think it's absolutely vital part of that multidisciplinary team working at neighbourhood level. So we want to influence that and to try and advocate for social prescribing in that new system. We want to try and help more people from our marginalised communities to access health and care services. And we can do that in a variety of ways, partly through social prescribing, but also through our networks and our communities of practice that we've got working through VONNE's health and wellbeing team as a partner with the system. And we also think that we can play a useful role in the region as supporting the social prescribing workforce, so creating opportunities for learning, for sharing, for development. So we'll be focusing on that as well. Next slide, please. So the next couple of slides just outline what that means in practice, what we'll be doing. I'm not going to run through all of this, but if there's anything on here that you're particularly interested in and want to talk, then please do get in touch. On this first slide, we talk about that system development and the comms and engagement is really important as well. We need to kind of, I nearly said fly the flag. I'm going to avoid that particular reference. We need to advocate for social prescribing because we are seeing some areas kind of moving away from it, and we think it's really important because there's lots of evidence that it works, and we want to share that and share learning as it develops. And we also want to keep that community going. So we've got a really strong, growing healthy communities network, and I'd encourage you to join that as well. I'll show you how to do that shortly. Next slide, please, Fran. And then the other 2 areas are this workforce, remembering that link workers are employed across all sectors, not just in the health service. There's social prescribing has been going on for a long time. But it's a workforce that needs support, it needs development, and as a system we can coordinate and we can work regionally so that we're not duplicating effort. And we want to look for other opportunities to grow projects, to find funding so that we can do more of these projects and innovate and bring new learning into the system so that social prescribing can continue to grow and develop. So that's what we're going to be focusing on. And I'm just going to wrap up with some thank yous, if that's okay. So, so thank you to everybody who's attended this morning. We hope you've had a good time, hopefully learned something, been inspired and enjoyed this morning. Thank you to all of our speakers for sharing their time and their expertise and their insights so generously. Thank you very much. Thank you to our project partners, the people that we saw in the video, or in the videos from Carlisle as well. The work that you're doing is fantastic and making a big difference to people. So thank you very much for all of your efforts. Thank you to the team at VONNE for helping to organise this and putting a huge amount of work into making sure that this morning could happen. And thank you to the ICB for continued support and funding as part of the Healthier and Fairer programme. And that's it, we've reached that. Please do consider joining our network. As I said, we've got a QR code on here. So it just means that we can keep in touch with you, we can keep you updated on events, on our work, on training opportunities, etc. And for those of you that are here from the VCSC, if you're not already a member of VONNE, then please do look at the member benefits that you could enjoy and consider joining up as well. And we've got a QR code there for you to find that information. Right, that's it. I hope you enjoy the rest of your National Social Prescribing Day, and hope you get a little bit of sunshine, and yeah, hopefully see you again at another event.
Thank you.
Thanks.